Welcome to the Naval Postgraduate School Center for Homeland Defense and Security lecture and webinar series. On behalf of CHDS and our co-hosts, the Association of State and Territorial Health Officials, the International Association of Emergency Managers, the National Emergency Management Association, and the CHDS Alumni Association, thank you for joining us. Today's webinar is the first in a three-part series discussing housing and shelter challenges during COVID-19. During today's webinar, our panel will examine how the pandemic has affected traditional disaster shelter plans for events ranging from hurricanes to wildfires. We'll also consider lessons learned from the early responses to COVID-19 and some of the new emergency model practices to provide safe housing options for our communities during these historically unprecedented times. A couple of administrative items that I'll note before I turn it over to our moderator. All participant audio is muted and all questions will be held until after our speaker's initial comments. Throughout the session, you're encouraged to submit questions using the Q&A box on your screen. We will answer as many of those live questions as time allows. We also received several questions from you before today's session, and we'll try to get to as many of those as possible as well. Today's webinar is being recorded, and a link to the recording will be posted to the CHDS Executive Education Program website after today's session. At the end of the webinar, there will be a short survey, and we ask that you take a few moments to give us your feedback on today's program. And now it's my pleasure to introduce our moderator for today's webinar. Clark Kimmerer is the retired Assistant Chief of Police of Seattle, where he served 31 years, the last 16 of which as second in command in the department. He served as Chief of Staff as well as Chief of Operations there. Clark also served as the Director of Seattle's Emergency Operations Center, coordinating all of the city's operations during activations for natural disasters and terrorist attacks. Here at CHDS, Clark is a frequent moderator of our executive education seminars for senior local and state elected officials around the country. Perhaps the most relevant experience that Clark brings to today's discussion is his work as Vice Chair of Seattle's Downtown Emergency Service Center, an organization there created to provide emergency shelter and survival services for Seattle's homeless community and other vulnerable populations. Clark, thank you for bringing your experience to today's discussion, and now I'll turn it over to you to moderate our program and introduce our panelists.
Thank you, Dawn, very much, and welcome to everyone participating in this very important webinar. It's my privilege to moderate today. I may have a few of my own opinions that I interject, but really it's about the panelists that we've assembled for you, and in particular about your questions, your comments. As I'm going to say numerous times throughout this presentation, you are all subject matter experts, and it is upon that basis that these sort of forums are generally successful and become kind of a formula for idea exchange and collaboration. I'd like to introduce my panel. Start with Donnell Harvin. He's the Chief of Homeland Security and Intelligence in Washington, D.C. for the Homeland Security and Emergency Management Agency, HCEMA. He's a PhD in public health. He has a number of other degrees, including a Master of Public Administration and a Master of Public Health. Prior to his position in Washington, D.C., he was the Department of Health research scientist, chief research scientist for the BioWatch program. And then he was also the Director of Special Investigations and Operations for the New York City Medical Examiner's Office. In his obviously abundant spare time, he is also a professor at Georgetown University in the areas of emergency and disaster management and applied intelligence. He's also going to be kind of my co-facilitator. I'm going to be going to Donnell fairly frequently to get a public health perspective on the management of disaster shelters. Denise Everhart is the Disaster Division Executive for the Pacific Division of the American Red Cross. Denise has more than 15 years of experience in the combined fields of disaster operations, project management, external affairs communications, and public relations. She is responsible for division-wide disaster operations for California, Oregon, Washington, Idaho, Montana, and the Pacific Islands. And you may see a chopper landing to take Denise somewhere that she's needed in the midst of this webinar, because every time I've talked to her, her phone's ringing off the hook, and she disappears frequently, but she's promised to stay with us for the webinar. Angie Morgan, Deputy Director of the Kansas Division of Emergency Management. Angie oversees all aspects of the Kansas Department of Emergency Management, including response and recovery, emergency planning, and hazard mitigation. She's the primary POC for all county emergency managers in the state of Kansas, and is a principal advisor to the Kansas Commission on Emergency Planning and Response. Justin Brown, finally, Chief, Office of Emergency Management for the Department of Human Resources in Washington, D.C. He's responsible for citywide disaster mass care, shelter, and rehousing, and is part of the D.C. COVID-19 incident management team. He's a career firefighter and paramedic, previously serving as Deputy Commissioner of the Boston Fire Department as an interagency coordinator for field operations in the New York Office of Emergency Management. Thanks to all of our panelists. Again, you are among many SMEs, about 519 by the current count. But we're going to start with our conversation with you all and then expand it out into the group that is assembled to share with us in this webinar. A couple of kind of opening comments. So the content of this webinar was developed through the thoughtful participation and input from our participants. We received about 140 questions by registrants. You are all this program's SMEs, and we thank you for your dedication, your expertise, and your humanity. Our 75 minutes together, because we have over 500 signed on already and probably more to come, I'm sure we're going to get to every single question you have. Well, maybe not. So we have picked questions around central themes that we believe are very important to all of you, all of your efforts in terms of the operations, the standing up, the implementation of disaster shelter and housing programs. This is, as mentioned before, an idea laboratory. That's how we move the ball down the field. And it's part of the center's ethos that we take these opportunities to exchange ideas, identify what needs to be done, maybe even come back to follow up, which is an offer we'll make you at the conclusion of this webinar. This will be an interactive webinar. We will adopt a public health, public safety, and emergency management perspective. This important series of forums and interactive discussions is founded on the Center's philosophy that our nation's homeland security depends upon continuous community capacity and resiliency, building through rigorous, continuous, and collaborative problem solving. Here's a question to all of our panelists. I will be asking them the same question in turn, and it's the broadest that founds our conversation. What are the most significant challenges of shelter operations in our COVID world? What are, in your determination, the priority gaps and needs? I'm going to turn first to Donnell for a public health perspective.
Thanks, Clark. I think that one of the opportunities we have here today is to do something that as emergency managers we rarely get the chance to do, which is to do an after action while the action is still happening. The protracted nature of this disaster allows us to take a break right now and take a look at what we've done and give us opportunity to continue to save lives. During this program, we'll talk about some key documents and some guidance that's already out there. But one thing from a public health standpoint that I'm curious about is our ability to manage all of the medical needs of those folks who are coming to these disaster shelters and any geopolitical issues that may weigh in on the ability to implement certain public health practices in these environments. For instance, if you happen to require the services of a disaster shelter and you're in a state that does not mandate masks or state or county that doesn't mandate masks or kind of doesn't look highly upon those public health measures, what does that look like from the shelter management standpoint? On the other extreme, if you're in a state that mandates masks, in a city or locality that does that, and you come to a shelter in need of support, you have no documentation, you have a medical condition that you can't wear masks, or you don't feel comfortable in those masks, you don't have that doctor's note, how are you perceived as well? And so to be able to meet everybody in the middle from a public health standpoint while still maintaining the health status of these structures that are relatively quickly erected is something that I think is a challenge.
Thank you. Justin.
So I think, as we, like Donnell said, as we start to analyze what we've been doing and where we're going and even preparing for possibly a second wave and starting to look at when this happens to us the next time, we're seeing a lot of patterns emerging. One of them is the interaction between, everybody here in this audience. I think the majority of folks come from a public safety background. And so this is really, for the most part, this is a health and human services disaster where the agencies and the organizations and the folks that we normally lean on to sort of lead our response to these things is a very different group. And so I think being able to plan to put the folks that do that sort of more health, human services, social services type work, and recognizing that there's a lot of disasters where the primary impact of the disaster is actually an exacerbation of pre-existing social and health problems in our communities. And so I think being able to focus on that and looking at the tools that we have at our fingertips, like how to use and expand virtual government so that we can keep people safe, how to coordinate our jurisdictions and our agencies better to provide a more seamless service to the community that we represent. Those are all key items that I think we can focus on, we can learn from, and a lot of us have started making those improvements already.
It seems to me, both based on Donnell's comments and yours, that these are systems that are somewhat self-determinative and individual to the jurisdictions that are setting them up, and there could be substantial variations. Where does legislative or statutory authority come into play? Just kind of broadly, can jurisdictions be ordered to do certain things, and basically as a matter of an emergency declaration or something like that?
So it's an interesting question to ask somebody from Washington, D.C., right? Because we're a city state, and we have the luxury of being able to determine what our policy is, make the laws, pass the laws, and do what we need to do in the city to take care of our community. It's a challenge in some aspects, but in other ways we benefit from that in a way that, for example, Angie probably does not, and the local jurisdictions in Kansas don't. But I do think that there is a way for us to look at the federal guidance, and this is something that we've all struggled with. We struggled with H1N1 too, where we get federal guidance, and it's the local government is where the rubber meets the road, right? So the federal government, the CDC, FEMA can give us and has been very helpful in providing a lot of best practices. As you know, King County set the bar with I think the first jurisdiction to use a hotel property for remote quarantine purposes, but it's translating that into action with the resources that we have in our own communities that is the challenge.
Angie, I think Justin kind of queued you up here, the great state of Kansas. What are you wrestling with? What's at the top of your list? What keeps you up at night?
Well, there's a lot of things that keep me up at night. Non-congregate sheltering is certainly one of those. I guess our experience in Kansas is somewhat different than other states, especially larger states or hurricane states. The mentality of our Midwesterners are that we stay with family and friends. So our shelter numbers through a tornado or a flood, something like that, are always very low. What we didn't plan for, I guess, would be one of our gaps, is more of a consequences of the impact that a health emergency has on our workforce. And whether that's our correctional facilities, our state hospitals, or probably what really put us in 100%, 100 miles an hour was the outbreaks in our meat packing plants. Kansas wasn't really on the map, so to speak. We weren't one of the hot zones, but when you quickly find out that 25% of all the exported beef of our nation comes from Kansas, we became a hot spot. And so we have several shelters over several cities for quarantine and isolation of our meat packing plant because they work in close proximity to one another, and weren't able to put quickly into those safety and mitigation measures at first. So we've quickly become landlords, so to speak, and had to form new relationships that we didn't have with other state agencies as well as local community partners. As we've talked before, Clark, our shelters are all run the same, regardless if they're for homeless or for first responders or for critical workers. And so the models worked quite well. We're happy to share some of our experience on that. But I think our biggest gap was we just didn't realize the cascading impacts and consequences to a public health emergency, mainly because none of us have ever experienced it. So we are learning as we go, and we're more than willing to share our experiences.
Great. Thank you, Angie. Just a quick follow-up. So in the past, when we think about disaster shelters, the need for secondary or accompanying or integrated facilities dealing with quarantine and isolation, the whole testing protocols, I mean, that's a new layer. I mean, it probably existed at some low level in previous disasters, but now it is quid pro quo, right?
Correct.
Yeah.
Yes. Well, when we were starting to learn about the non-congregate sheltering program and opportunity through FEMA, it kind of all exploded all at once. So our correctional facilities had an outbreak in the eastern part of the state, while our three largest meatpacking counties in Southwest, about 300, 400 miles apart, were imploding at the same time. And so it really is a community effort. You have to work with industry, local public health, local law enforcement. Certainly county emergency management is critical. We were able to use the guidance that the federal government provided us with through CDC and FEMA. We worked with our Department of Children and Families. They have lead for ESF 6 in our response plan. But they were not equipped to do sheltering management. Other states like Florida have state managed programs. More, our state's always been, and our agency's always been in a support role for a very short term, because thankfully the Red Cross comes in and offers vouchers for the night, and people just don't want to stay in the shelter. So we quickly had to implement things, processes with local public health on how employees would be tested. That was also coordinated with the plants. You can imagine there's a certain amount of privacy and, negativity, I guess, that could be associated with that. And that's just kind of a stigma that you kind of have to work out through this. The whole notion that this is a virus, and you're not an outcast from your community and those type of things. But we have a process that we worked out with the local public health, and they do the registration. Transportation is provided by the local community to our shelter manager, and then they're well cared for as guests. 3 hot meals a day, snacks. We take into any of their religious beliefs, or certainly dietary, hard word for a Kansan, and make them as comfortable as possible. We don't get into any altercations if they want to leave. That we notify local public health again, and then it's all handled locally.
Great. So you've got a system, and we're going to continue to explore that. And I guess what we're focused upon today is, what do those systems, look like or need to look like? How can we put our heads together about, meeting gaps and needs? By the way, it's beautiful weather in Kansas right now, apparently, and
it's 80 actually.
It's great to see you're actually broadcasting from outside in a beautiful farmland area. I want to turn to Denise Everhart, who's got an even more broad perspective about the management of disaster and disaster shelters.
Yeah, we're dealing with a little bit of a different set of problems than some of what my colleagues just talked about. What happens when you have a pandemic and then you have a concurrent disaster? And then in this year, what happens when you have a series of disasters like all of the Western wildfires the same time as you are having Hurricane Laura, then more Western wildfires, and now Hurricane Delta? It is stretched, an already stretched organization, not just us, but but our partners, public health, local counties are all stressed to capacity. In addition, we cannot use, we came into this with a set of ideas. We said, okay, we normally do congregate sheltering. That's what the Red Cross does in partnership with local government after a disaster. And we said, going into this, that will be the option of last resort. But as I saw Labor Day weekend, when you have 750,000 people evacuated on the West Coast, finding hotels in a timely fashion is not possible. So we knew going into this with hurricane and wildfire season, we knew we were going to have to open congregate shelters. And how do we, as Angie said, how do we get people to be willing to come in to help with that fear factor? Our first few disasters, we had people sleeping in their cars in parking lots. And then how do we transfer them into hotels? And we'll talk about it a little bit more later, but that has not been a smooth process. None of us were in the hoteling business before now. And then one of the big lessons that we've learned has been, in some ways, when we put them in hotels, people are out of sight, out of mind. So if you have people in 293 hotels, that is the equivalent of still having 293 shelters. So you still have to provide those wraparound services. And then the final thing was working out the infection protocols with the CDC and our partners at local and state public health. We've hit it, you talked about it before, Clark, we've run into it in small doses in shelters with norovirus, where we've been able to set up a quarantine and get people out of the shelter so the whole shelter doesn't get infected. But this was just a whole nother level. And so it took kind of everybody to come up with a plan. We've executed and consistently had to adjust that plan, and we're adjusting it right now as Hurricane Delta comes in an area that just had a hurricane.
So Denise, I wanted to comment on one more thing. I'm going to go then to Justin, and then we're going to open up the participant forum. One of the questions we ask ourselves, I call it the Donnell question, is if you knew a year ago what you know today, and from the vantage point of the Red Cross in particular, what would you have been working on? What would you have attempted to implement or perfect or done differently?
Well, we would have started recruiting more volunteers earlier, I'll be honest. You cannot have enough volunteers in a season like this. But systems to register people and get them assigned to a hotel room, we've been building those systems on the fly. Even now, we're taking, in California, we have, I think it's 26 different spreadsheets that we're trying to pull into a database so that we can really track who we put where and how. None of us had the infrastructure built to take people in and kind of track them through the entire process. Okay, you've come in, you've said you need a place to stay. Let me put you in a hotel. Let me manage your daily feeding, add in some damage assessment or power outage or whatever information, and then have the conversation with you about whether or not you can return home. We've all kind of lost a level of visibility on that. And we're building systems as fast as we can to help our field people and our state partners and our local partners actually track people through the process in order to make sure that we don't lose anybody.
I think as we go through this webinar, we're going to be attempting to build a house, as it were, or at least try to figure out the components of a system. And of course, that whole registration and tracking challenge is huge. There's another one I want to close out this session with Justin that we want to talk about, and that is, well, how do you establish the standards of care that you at least aspire to in the operation of a shelter system, a disaster shelter system? And by that, it's not entirely a public health or medical concept as much as, well, what are you prepared to offer? What are you prepared to support? And talking with Justin earlier, we chatted about, well, there's this debate about trying to build systems that are a concierge kind of level, or what we think of as a traditional shelter, or even farther down the line, just basic subsistence. Justin, why don't you give us a couple minutes on that thought process and the challenges that it presents?
Sure. So this was interesting for me personally, and I think that a lot of jurisdictions across the country sort of grappled with this. It's a combination of what people need, what resources you have available, both human resources and actually the fiscal resources to support it, and trying to identify what are you going to give people. So when you're going to put people, and we all now talk like hotels are a given. I certainly come from a jurisdiction where hotels will not be a given probably in the near future. But once we get people in there, there's this sort of interesting interplay in a public health and human services emergency where we have a lot of people like me who come from a public safety background, very rigid, very SOP driven, very, okay, we're going to put you here and I'm going to give you this, and this service, and that's it. But a lot of the folks that come in have a really complicated sort of web of social service needs. If they're part of our existing system for people who are experiencing homelessness, they're already enrolled in a wide variety of social benefits and wraparound services that we want to keep going. A lot of people who were not at that point are slowly becoming dependent on some of those emergency and social benefit services. So there was a really interesting interplay and discussion going on about the viewpoint that we both brought to it, and it clashes at operations, right? And so those are things, I think what I would say is really sort of for the emergency management folks here, the scope of work in the contract of like what we're actually going to provide to people, and then making sure that we communicate that not just to the clients, but to our own agencies, to our own staff, to our political leaders, who often want, and for very good reason, to provide as much as humanly possible to everybody who's there. And I think, it's probably not lost on the participants that we have here today that this is a blue sky emergency. And so people come to this with very different experiences of what the emergency is. When we provide them with emergency food or emergency shelter, whether it's congregate or non-congregate, they come with expectations. And their expectations in this case are not driven by seeing smoke in the air and rubble on the ground. And so, I kept reminding people like, look, I want to get people the best food we possibly can that's the most appropriate to keep them comfortable and in their homes. But at the same time, these are disaster rations. We are in a declared disaster. And it was very challenging to remind people of that. And so I think one of the takeaways for me is for all of us to think about that and talk to our political leadership, our social service agencies, our social benefits, our partners like the Red Cross, and really come to a clear understanding of when we say disaster housing, it's a little more nuanced than that. And so where do we really land? And I think that's probably, for the standard of care, that's the piece that we can work out better for the next time.
Great, thank you. So Donnell, you and I are gonna open up the participant forum. The questions that we're going to pursue right now among all of our panelists came from the participants of this webinar. We asked them to put down their questions and comments. When they registered, we got a boatload of them, about 140. So the staff, Dawn and others at the center did their best to kind of consolidate. And I think we're going to be looking at some fairly broad areas, jurisdictional questions, certainly disaster shelter operations, what's the state of our stock of disaster shelters or our options? And we've already touched on the staffing challenges. And Denise will be providing volunteer applications for the Red Cross at the conclusion of this webinar. So Donnell, after what you've been hearing so far, I mean, what stands out, as we're thinking of the systems that we are attempting to build? And what we need to address as kind of job one.
Yeah, I mean, it sounds like we have a convergence here of one of the busiest disaster seasons from an emergency sheltering standpoint, combined with trying to build the plane in the air from a public health and infection control standpoint. Denise, Justin, you're probably familiar from what I've consumed. This is on record the busiest year for the Red Cross. I think when I checked last time, it was about 800,000 overnight stays, which is I think three or four times more than the normal average. Yeah, and with the great state of Texas owning up to about 200,000 of that just in 1 year, which is basically what you normally would do in a year. When you look at that volume and you look at the need to now not have people together, right, and have people separately, it brings to mind a couple of issues from a public health standpoint that I'm curious about. One, and we'll put the link in this document out for the audience. The CDC has done a really good job in providing some really steady guidance from infection control, not just for multiple audiences, not only for the folks who are going to these disaster shelters, but the folks who are running these shelters. One of the things I'm particularly interested in is the isolation provisions. Assuming you have all the resources, assuming that you have all the resources to screen folks and to kind of segregate folks to, take that back, to identify folks who may be sick or people who present as, like, I was in my home, we were told to evacuate, I have COVID. What does that isolation look like? What does the stigmatization of that look like? And then the other host of public health, I'll just lump these under the public health issues, interpersonal violence, domestic violence, especially if you don't have people together and you have, as you mentioned, Denise, a whole lot of individual shelters. You don't have eyes on the situation there. Human trafficking, child exploitation, all the things we would see in the normal environment. How does COVID and what we're doing right now make those things worse?
And as we pursue these questions, again, I want ideas to flow, not just from us, but from our participants. And so when you think about, isolated folks that we don't have eyes on and the attendant public safety risks that occur there, is there the potential for some sort of enhanced 911 sort of system, or hotlines or things like that? I mean, in domestic violence, for example, you've got the possibility of preventing something if the right people are engaged early on. Those kind of ideas are the ones that I think we're very interested in. So we're going to now head to the participant forum. Again, questions developed from your input, the priority questions that we saw, maybe asked over and over again in your registration questions. Obviously, we owe a debt to you in trying to figure out how best to talk about the challenges of designing and implementing disaster shelter systems. And again, we want to populate this webinar with your ideas. Here's how I would like you to think about it, at least in this at one level. The same question I posed to earlier. If you knew a year ago what you know today, what would you do differently? So Dawn will be tracking the questions and comments that you enter, and we will get to them in the final 10 or 15 minutes of this webinar. And anyone that we see that tries to answer that question, which I think is a pretty profound one, probably goes ahead of the list, but we're going to try and get to as many as we can. So picking up on our public and participant forum criteria, let me ask Angie, and then I'll turn to Donnell. This is an issue about jurisdiction. Many folks wrote in and said, well, who's in charge here when something happens, particularly if it's a broad or wide area disaster? And oftentimes more rural than urban. Is it the local? Is it the county? Is it the state? You have to wrestle with this, I imagine, in Kansas, unless you have a very defined process. But Angie, how would you kind of start the answer to that question?
Well, our laws are pretty straightforward. Our local jurisdictions are always in charge, and the state is there to support, as well as the federal government supports the states when we request their assistance. So all the shelters that we've done for the non-congregate areas have been at the request of the city or county themselves. And it's primarily, there are some cities and counties within Kansas that do have their own shelters. There are 3 that are supporting universities. And then we have some others that are just doing first responders. But when their resources are overwhelmed, or their capacity is overwhelmed, like any other disaster, regardless if it's a flood, a tornado, or a wildland fire, that's why we plan for all hazards. Then they come through the county emergency manager to the state to request for assistance. And so a couple of the shelters were started at the correctional facilities within a city or a county because they were concerned about the spread within their staff. Those same staff were transporting prisoners to other counties or state facilities, or their staff was at the hospital, the county hospital. So the goal's been to mitigate the spread of the virus, and where those folks don't have a place to isolate or quarantine within their own home. We want to make sure that they have a safe place to go while they're waiting for the test. We work with the local public health and our state partners to get those workers tested immediately. And we carry those results back to our state lab because in some of those areas in the meatpacking plant, that's a 5-hour drive. So daily couriers are constant in Kansas to our lab. So we can quickly process those, some as early as 45 minutes. We have the Abbott test kits that are, if they're positive, we follow up with the nasal swab for confirmation. But it's the state's always in support of the locals, and the locals are the ones that provide the local law enforcement. They're the ones that tell our shelter managers that who's coming to our shelter and any special needs that they have. They tell us when they're able to be dismissed. And really the state's just taken some of that weight off as far as getting the contracts with the hotels and the meals and such.
Right. I think, that's probably a prevailing model, although, California seems to be very much centered statutorily on counties being the, jurisdiction that coordinates emergency and disaster.
Ours is built on a county by statute, but we still work with our local communities through that system. And,
all disasters are local, right?
Right.
So Donnell, given that there are going to be some differences, obviously, in jurisdictional kind of lead, and it's going to depend on the nature of the disaster too. If it crosses many counties and many cities and things like that. But how do you size up the public health overlay? I mean, in DC, it's pretty obvious who's in charge if something happens in DC. But then there are, city, county, state health officials, and some of them with extensive kind of reach in terms of jurisdiction and prerogatives. So what's the public health overlay on that look like, and where is it? What are the gaps that you're seeing?
Well, we have a system of federalism, right? And so the federal government can put out as much guidance as they want, and it's left to the states and the creatures of the state vis-a-vis the localities, the cities and the counties to adopt that or to come up with their own. And many of the CDC guidance is very explicit in the fact that these are guidelines that you should refer to your state or local health department. And so that's where we've seen, not just in this particular topic, but in other areas where there's been divergence from CDC guidelines, or where there's been adaptations of the CDC guidelines that haven't really met the mark as far as proper infection control, to be quite honest with you. And so, you can't talk about COVID in a vacuum. You have to talk about COVID now as a political disaster. And had we had this discussion 2 years ago as a public health person, I'd say, keep your politics out of public health. Unfortunately, however, this is, the COVID has created what I like to call a complex disaster. And it's not in the province of any one type of jurisdiction or discipline to manage. We all have to come together. And so we've also seen concurrently attacks on public health officials at the federal level, at the state and local level. We've seen doxing. We've seen all types of threats to their life. We've seen public health officials resign or retire early because of COVID, because of threats they're getting. And so Fortunately, there's a long history of public health and human services collaborating particularly well together. And so a lot of the services they provide overlap. Ultimately, it's for the holistic greater good of the stakeholder that they're treating or taking care of. But in this particular case, I'm interested in hearing from Denise, Angie, and Justin, particularly if they're seeing different measures being implemented in different jurisdictions. And if anyone's collecting data on this, because at some point we will have to do a formal after action. We will have to be introspective as a public health, public safety community and see if what we did was effective.
Yep. Well, Denise, I think that's a question you can start answering. I mean, have you seen consistency? Have you seen attempts to find some unifying practices or uniformity?
Yeah, the biggest challenge we had was we started out planning for this while public health was paying attention to all of the systems they had to put in place. We were trying to plan for hurricane and wildfire season, and FEMA and the Red Cross sat down with HHS and said it's coming, and HHS said, well, you can't open congregate sheltering, people will get COVID. And we said, well, if there's a hurricane or a wildfire, we're going to have to open congregate sheltering. We put a ton of systems in place. About half of them worked really well, and the other half we're having to revise. We had plans for using college dorms and reaching out to schools and seeing if we could do that. And nobody really planned for the fact that when the schools closed down, all of the kids left all of their belongings behind. So college dorms were immediately off the table. We had planned for opening a lot of smaller shelters and using things like college dorms, Girl Scout camps, hotels to alleviate the burden. There are not enough places, we've learned in this kind of horrific disaster season, to put people. So we're back to opening shelters. And so we had to go back and say, what happens when we have to open a shelter with more than 50 people? And basically, we're consistently trying to revise our doctrine. And our biggest problem has been, and it's been the problem for the entire community, not just us, but if you look at California Office of Emergency Services, or you look at the Salvation Army, or any of us, is that we're adjusting on the fly, but I don't know that we're capturing it all. Nobody's got enough time to write the new doctrine, so there's still the old doctrine out there. So a lot of this comes down to relationships and conversations that we're having with jurisdictions. Hey, there's a storm coming your way. There's a wildfire risk, and we're having a conversation that, look, available hotel inventory in your area is not going to be a solution. So let's come up with another solution together. It's not an ideal way, but in this year, we've kind of had to adjust some of the things we're doing, and then best practice, lean on that whole community to help us. We have jurisdictions just in California alone, which is part of my area, where the county has booked hotels, the Red Cross has booked hotels, the state has booked hotels, and occasionally another nonprofit will put people up in hotels. And once again, what is the consistent, how do we keep track of all of those people together? The national voluntary organizations active in disasters, VOADs, and the local VOADs are more important than ever, because it's going to have to be kind of that whole community solving this problem. One of the things that I'm struggling with right now is we said at the outset that if we put people in hotels, we are still going to feed them 3 meals a day like we would in shelters. We're seeing more people come to hotels, which is understandable. Do I want to sleep in a cot with 49 of my closest friends or have my own hotel room? We're having more people go to shelter. We're having to feed them across a wide expanse of area because now we're in 293 hotels. That takes a manpower resource and a financial resource. And our partners, the whole community is kind of struggling with this. And it goes back to what Justin was talking about. When is it disaster feeding? Are you being fed because you had to leave your home in the middle of the night for a disaster? or are you being fed because your home was destroyed? If your home was destroyed, are you working? Are you not working because of the disaster? Or are you not working because of COVID? And so all of those questions just make every interaction and all of our plans, we're constantly having to readjust. And that's really been the challenge of this year. We're capturing it all. And we're having little mini after actions, right? I met with Cal OES yesterday and we were talking about, okay, when the next fire comes, and we all believe the next fire is coming, how do we better do hotels?
Yes.
And so they decided they would give us their hotel rooms and the Red Cross would book them all, but that way they'd all be within one system. Those are the little adjustments that we're making as we go, but there's going to need to be large after actions, but I don't think we can wait for it, because not only do we have storms now, there's
right. Which
more
is what,
coming.
What Donnell's point was, we need to be doing after actions even when we're in the middle of the action.
Yep.
I've facilitated probably close to 250 seminars for the center, and I can't think of a single one that did not have some application of the thought that left hand does not know what the right hand is doing. We are not analyzing what works. We're not sharing it as much as we could. Now, I don't think anybody's going to be arguing for a national system, but it would be nice to have a national database that's accessible, right? And it is, I have great chagrin in my own career. So many significant incidents never got the treatment they needed by way of an after action process. But I think, you're talking about real world problems that are occurring in real time, and you're deconflicting them, but it's conceivable, but that the thing you're dealing with, say in California, Angie's also dealing with, and maybe not, you have things to share that may not have an avenue to do it, to accomplish that. I want to turn to Justin, because this is another big issue. Angie told us that in, say, Kansas, for a lot of the disasters, majority of people are sheltering at home. Now that begs a whole lot of questions, particularly in a COVID environment, right? I mean, that, the needs they might have, even though they are not going into a congregate shelter or hotel room, still might exist, that those wraparound services may still be a requirement or be a greater priority given a disaster, for example. So Justin, you told me about a program that you've been working on that attempts to increase that connectivity to folks that are sheltering at home, build their resiliency and give them options, and give you an opportunity to have insight into the shelter populations that are not in the shelters, but are at home. So give us a few minutes on that program.
Sure, and I think the best segue here is that maybe Donnell or Angie mentioned this before, but when we bring people from their homes to a government facility or a nonprofit facility and we care for them there, we bring all of the various challenges that they had at home or where they were living before into that facility. And I think for most of us in public safety, we've had the experience that once we start doing something, we can work it out. We're pretty good at it. We get going. The challenge is in the transitions. And so one thing that has really been a challenge for us here, the nexus between your last question and this one, is that all of this is taking place inside of a public health environment. And I think that not just interjurisdictionally, but in terms of the agencies, we've got organizations that are making decisions that feel to them like medical and health decisions that they don't normally make and they're not prepared to make. And most of us have public health departments that are so stretched thin and challenged, they can't provide the level of technical assistance translating high-level federal and state guidance and best practices into that tactical local level environment. And so I think there's a lot of feeling on behalf of the other agencies that are now the first responders, even though they don't have funny hats and shiny badges, right? That they're now the first responders and they don't have that same level of support. So with that in mind, we decided very early on in a lot of jurisdictions, we realized, you know what? We normally tell people, stay where you are, but if you really need help, come to us. And we practice all the time, right? We practice setting up disaster service centers and the large congregate shelters. And a lot of us, we have a phenomenal team in the district. I worked in New York. I know they're amazing there. They can turn these things on in an instant. They're amazing at doing it. even under challenging conditions. But we realized, you know what, we got to turn this on its head. Our goal here is actually tell people stay home, and we're going to find some way to get you what you need to keep you safe in your home. The priority for that was those who are COVID positive, who we did not want out in the public interacting with people, right, in order to flatten that curve. And the other group were the people that were the most vulnerable, the most highly vulnerable, the at-risk populations, such as the elderly, who we really wanted to be able to keep them at home. And we felt an obligation, rightly so, I think, to say, if we're telling you, or a medical provider is telling you, you got to be in quarantine, right? So home quarantine, as opposed to remote quarantine, you got to stay at home. We're going to provide the emergency disaster services that we would normally provide to you in a congregate setting. We're going to provide those at home. And in the district, we'd already long been talking about improving our family assistance center process and the things that we do for people after disasters. And so what we really did was in an unbelievably compressed timeline, and I know a lot of others have done this, and the Red Cross is still building out some of these systems on behalf of local and county governments. But what I think as a group we've been trying to do is say, hey, let's build these systems on the fly. It really is virtual government. It's service delivery government. It's where the focus stops being on buying and creating big things, and rather actually the focus on the business process rather than the stuff itself that we deliver to people. It's a logistics challenge. In the district, they really successfully built out a virtual family assistance center that has an online portal and a telephone portal that you can call, and you can get food, infant nutrition, diapers, hygiene, sanitation, the kinds of services that we want to provide to people so they don't have to come to our shelters. Because as Angie and Denise pointed out, we're now talking about a shelter that used to get me 200 to 400 people in it is now for 80 people because we're trying to de-densify. And so we're trying to keep people at home doing that in the district. I know a lot of folks are doing that in other areas, but we are really throwing together virtual government on the fly. And again, it gets back to the fact that this disaster largely is an exacerbation of the social issues that we already were challenged with. So how do you get people quickly on SNAP and TANF and EBT and pandemic EBT and all these social programs that are out there to support people? But we used to have these sort of like very bricks and mortar systems for doing that. And we're trying to get away from that and make that is our disaster response. So to me, and this is the end of this, is our first objective since day one has always been make sure people are enrolled in the social benefit programs and the agency programs and the government programs that we already have to support people, so that we have as few people as possible in the disaster and emergency system. And then for those people, we have the combination of what the remote quarantine systems and that home quarantine system, the non-congregate shelter and those sorts of things, which really are very taxing for us.
Great,
so,
thank you.
Clark, can I do a follow-up on that?
Yeah, a quick one.
So I think Angie and Justin and Denise all articulated, this prevailing hope that people could shelter in situ where they were, and then we bring the services to them. Let's go to another scenario in which they cannot shelter at home because their home is not safe. We're in a very active, still hurricane season. Justin, I don't know if you were in New York with me back in Hurricane Sandy, came towards the end of October, so we're not out of the clear yet. It was cold.
Started snowing.
People had no power, and they just couldn't stay at home. What does that look like? Because I'm looking at some of the questions that folks are doing. What does that look like on the ground at these shelters, implementing some of these CDC guidelines? Are you able to keep people 6 feet apart? Are you able to put hand sanitizers? Are you able to have all these things in place? Are you able to give them all the PPE that they need coming in? Are you able to segregate those that you mentioned, Justin, at the highest risk, those who are over 65 years old, who have underlying health conditions, who are mothers who are nursing? What does that look like on the ground when you cannot keep them home, or Angie, in the case that you talked about, they can't go to a friend's home?
Actually, I'd like to just open up that question to all of our panelists. Actually, Denise, do you have some thoughts on that? I mean,
Yeah.
we're talking about infrastructure of the shelter system, and Justin's presenting, of course, one that has to do with people staying at home, but just generally, you know, what is it that we need to make sure is part of the critical infrastructure of whatever the shelter environment is going to be?
So, and that's really at the heart of what we're doing now and the work that we do with the county and the states. It's actually easier in a hurricane area because we have 4 or 5 days to get the shelters set up. We can move cots and barriers and plexiglass and masks and hand sanitizer. One of the concerns we had going into this was actually the wildfire or possibly earthquake, sometimes even a tornado, the no notice events. And so we did set up what we call temporary evacuation points. And it's where inside or outside, we would bring people, keep them at a safe distance in their cars, if possible, to buy us time to set the shelters up correctly. We do have a firm masks required in shelters policy. We have a firm 6-foot distance. There are a lot of different things that we put in place that we are holding firm to, but it's the notice that allows us to set up the shelter correctly.
Maybe I'll turn to Angie on this one, just as a follow-on. So when we look at, say, the congregate shelter, or, you know, we don't have hotel space, and it's probably worth noting that we probably have a surplus of hotel opportunities and options right now. If the world comes roaring back, well, probably not as much as we need, but maybe it's going to be even more attenuated, worse, after we get into a post-COVID environment, right? I mean, Washington, D.C. is probably running 40% occupancy of their massive hotel system now. If the world comes back again, they operate at 89% of that hotel capacity. So that's, I mean, but that's just one of the wrinkles here. Angie, what I'm interested in, to follow on what both Denise and Donnell said, was, well, in a congregate setting, there are a lot of dynamics. It's not just about 6 feet apart and hand sanitizer and masks. I mean, people are going to congregate. They're going to naturally gravitate to areas where they can socialize. Families have a different dynamic. There's going to probably be folks that want to go outside and have a smoke, all kinds of things like that, right? So when you think about, you know, the design of a disaster shelter, what are the other things that are coming into mind?
Well, as I said, our mentality in the Midwest is different with our ice storms, our floods, our tornadoes. Again, we have a lot of warning usually, even during severe weather season. We know April through June is, you know, it's ripe for tornadoes. And so we don't see those large numbers. We have a lot of people that have generators or wood burning stoves in the winter, and farmers get ready for their cattle. So we don't see those types of things, but we have done a lot of the barriers in the non-congregate sheltering. At first, the numbers allowed us to have 2 hotels in each one of our counties, one that would treat positive COVID, and then one that just needed to quarantine while their tests were coming back or they were a close contact. So we've since learned that we can put barriers with different sheeting and zippers and access, where we can just lease one hotel now. And we don't prohibit them from going outside to smoke and stuff like that, but we do make them do monitoring checks. Our staff has to do temperature checks. We do have hand sanitizer. We do have PPE, appropriate PPE at all of our shelters for both the residents and our staff workers. So, the more that you have planned, I think you ask us what would we do differently if we knew this a year ago. And certainly that would be all those lessons learned that we are now able to capture to save resources. And, a lot of it's common sense, trial and error. If we had to set up some shelters that were for larger population, we would implement those same protective measures now that we've found doing the non-congregate sheltering.
It's those model practices which we're trying to get at here. This is the beginning of a conversation. And of course, well, the immediate follow-on that may become a matter of evangelism for most of us is, and how do we make sure they're shared? How do we make sure that what's working in other places, other than by word of mouth, and that goes a long way, professional association, right? We were going to talk about staffing. I want to get to Dawn with the live participant questions. Staffing is a huge issue and maybe a crisis. I think Denise keyed that up early on. One idea that I've heard and I want to pass along is, we do our COOP and COG planning, but we do that generally as a theory to, repurpose personnel when the population, when the staff levels go down because of, say, pandemic or something like that. And that could still be the case, obviously, in the COVID environment. But what about taking the COOP and COG plans and doing that same calculus to augment staffing that's needed in disaster shelters, to reassign and repurpose, which often involves retraining? Anyway, we've got stuff for about 10 webinars right now so far, but I'm going to leave you with that suggestion, maybe as a model to take a look at all the things we do right now that actually could be redesigned or reimagined to support things like the staffing of shelters and things like that. Dawn, you have some questions from the participants?
Yes, Clark, lots of great questions coming in today. And just a programming reminder for folks, we will be doing another session, and Clark will tell you about it here at close next week, focusing on homeless and vulnerable populations specifically. So if we don't get to those questions today, we'll provide information as we wrap about that session next Friday. Denise, the first question that we have here for you is particularly in regard to those no-notice events. Any recommendations for local organizers in that first 12, 18 hours before shelters, even congregate shelters, can be stood up? Where do you do with people? Where do you get masks? How do you distribute those in those first hours of a no-notice event when there's housing and sheltering needs?
Yeah, it's one of the reasons we set up the temporary evacuation points. Was we knew, even for us, we have volunteers, but sometimes it takes hours to get volunteers out to help set it up. So ensuring that everybody has seen the protocols and understands them, stockpiling what you can for hand sanitizers and masks. And what we have ended up doing in the no-notice events is either having people stay in their car, if it's not a weather event or the smoke isn't so bad, if we can have them wait outside, or quickly, as a rule number one, set up a temperature taker and make sure that you have extra masks, and then start putting X's on the floor so that people can be told where to gather inside, and just that basic guidance while we try to process it. Larger spaces are better. We like to use parking lots or a big gymnasium or something so that we can keep as much space between people as possible. And then local volunteers, and not just Red Cross volunteers. If they want to be Red Cross volunteers, redcross.org. We're always taking volunteers, but all of your local community groups, state employees, county employees, anybody you can take sheltering. We shared a link. There is shelter training and COVID safety training available for everyone. The more people at a local level that we can get trained in the protocols that we have in place, the better we can respond, especially to those notice events. That's the world I live in. I can't wait for people to fly across the country, which is what the Red Cross does. We have to be hyper-local.
Can I get a follow-up, Clark?
Sure, get a quick one because we want to get
really quick. Denise or Justin, have you seen a decline in volunteerism for shelters over the COVID period?
Yes and no. We've seen about a third of our workforce, for whatever reason, doesn't feel comfortable going out. They might have a health condition or something else, but just to give you an example, during the Oregon wildfires, in the first 5 days, we had 1,500 people sign up to be Red Cross volunteers. So we trained them and got them out as fast as possible. So yes and no.
Clark, our next question is for Angie, but then I'd ask after she answers, certainly open it up to the full panel. Angie, the question is in regard to your experience with the meatpacking industry, how did you and local officials work with a population that you needed to house and shelter who might have some apprehension about interaction with the U.S. government?
That's a good question. Primarily the meat packing plant industry are not from Kansas. So there is some hesitation when any type of government officials are involved, particularly law enforcement. So we were very aware of that and cognizant of that. When CDC came in, we brought that to their attention. They worked directly with the plant officials, and I think that helped for the plant human resource officers and their health clinic to work directly with their employees. We didn't use the National Guard in uniforms. There were a couple of cities where we had to use them the first 24 hours till we were able to get Department of Children and Family staff in there and trained on the proper protocols and safety stuff. So we were very aware of that because, again, our goal was public health, not to spread the virus, not to have to shut down the businesses, and alleviate any concerns of the person, regardless of their race, religion, and all that other stuff. So we were very aware of that and very sensitive to that, and still are.
Like you've said before, Angie, it's about taking the measure of interdependencies and cascading effects. And, it could conceivably be that if you've seen one disaster shelter operation, in a real sense, you've seen one.
Right.
Because they're going to be individual and unique depending on the populations you're trying to support and serve.
And as I said, each one of our communities is different. We have 4 that are supporting primarily meat packing, but that doesn't mean that first responders who are also exposed or medical professionals wouldn't also be housed in the same shelter. And we have that in the eastern part with the homeless and the correctional facilities. So we're very, very aware and sensitive, and disaster is not the time to make those judgments.
Clark, we have a couple of questions here directed at Justin and Donnell from the district standpoint, but again, open it up to the full panel as answers are appropriate. What special security concerns are you all looking at and dealing with differently? Obviously, those are always an issue in sheltering and congregate care circumstances, but how are you dealing with security concerns differently when some or all of your shelter residents are masked and some of the other distancing concerns in the COVID context?
So I think this is, an ongoing challenge for every jurisdiction that's running it. I mean, like as was said earlier, none of us were in the hospitality business before this started, I think this is also just one of those things. Anybody who works in human services, and frankly, my experience in human services is limited compared to a lot of people on this seminar. But it's messy, right? When you deal with a large group of people, it's messy. It's going to be messy. It's never not going to be messy. And that's what's so amazing, frankly, about our social service personnel is that they're used to working with people's conflicting interests, the different ways that people live when you bring them together, the challenges that incurs. One thing that we struggled with really up front was enforcing those rules of the shelters or of the mask wearing. And it's really, it was interesting to sort of back up these arguments. People say, the end all for everybody, right, is always call the police, right? Just call 911, call the police. When we have a problem in the shelter, we have a problem somewhere. And the reality is what, in a COVID environment in particular, what did we think the police were going to do when they show up? Take the person who's potentially COVID positive and bring them to central booking and, put them in a lockup. And, so a lot of the things that we rely on to solve problems for us aren't there. And so I think, again, this renews our focus on the social service agencies that are now the frontline workers. So getting the behavioral health workers in and having good case management and having making sure that our staff are trained to sort of diffuse those problems up front. It really, it's not just, I'm not a social worker and I was very skeptical, and it's amazing what our staff is able to do and how many problems they're able to de-escalate and relieve before they get to that point. And that's really got to be our focus, because the calling 911, calling the police, calling the fire department, is really not a first line option anymore for us. And you got to walk back through the system where each solution is going to get you. One challenge for us is I think for everybody in this is, if you kick someone out of a facility, what happens to that person who is COVID positive or has symptoms? You have to weigh the balance of what is their impact in that facility versus what are their impact on the community if they become sort of a vector in that local community for the virus. And so I think that's a constant challenge, but I would say that putting the investment up front in the social services, the behavioral health, the things that people need, if you give people really terrible food in a shelter, and we knew this from previous disasters, not COVID related, they don't want to be in that disaster, right? So they don't want to be in that shelter if you're going to give them poor food and you're not going to give them services and they can't talk to their family. So being able to have communication, having as normal a life as possible. And that's that interplay between the public safety people like me who are like, I don't know, here's the 10 rules, and if they don't follow those 10 rules, tell them they got to go. Well, it doesn't work like that. And so we all learned this lesson pretty quickly. But I think we know enough now that we can share with each other what some of those best practices are, so that we can avoid those problems in the first place.
And in 30 seconds, Clark, just to add to what Justin said, in this environment that we live in right now, calling the police to a shelter is probably not going to net you the results that you want. Many folks on the line are trained law enforcement officers. Myself, obviously, Clark and Justin know about this. When police officers show up, they have a limited set of tools to handle these type of issues. And you put them in the position that they almost feel like they have to act. And if they don't act, there's a problem as well. However, you have to balance that with the fact that we are tracking COVID-related interpersonal violence, particularly as it pertains to the compliance or non-compliance of mask wearing in public spaces, whether it be restaurants, government places, other spots. So you really have to have, I think, those interventions in place from the social standpoint that Justin talked about, and then have those people trained very, very well to kind of, steer off these issues that may arise of, COVID-related concerns that people may have, whether it be social distancing or mask wearing.
But the potential model, which I've seen, and is, staffing dependent, that you have embedded security, that officers maybe in a much softer kind of uniform and that sort of thing are almost like school safety officers. They are part of the internal security framework of particularly a large congregate shelter. Is that worth thinking about? Is it too problematic?
I think for a lot of communities, some of these folks, our shelter populations and our healthcare facilities already have security that is used to dealing with those kinds of social interactions. And so very often they are the best at handling those in these environments too. But like everything else, we're very constrained by what people felt comfortable coming to work in their environment. I think a big takeaway for us, if we're talking about solutions, is everybody needs to be really re-examining. And I know that we're all doing this now, but what does our disaster workforce look like without the silos that we're used to having in our respective communities? And so if you are, whether you're the District of Columbia or the state of Kansas or San Francisco, what is a disaster workforce? Because a lot of us have relied on employees from agencies that have nothing to do with emergency response, nothing to do with the pandemic or healthcare or human services. And they've stepped in and stepped up and quite frankly, kept us going in so many instances. And so whether it's training folks who we would not normally think we would rely on in the Red Cross trainings, right? So creating a mass care task force that's truly interagency, so that you have folks that are not normally involved in that effort up front. And that includes the security piece. So getting that disaster workforce prepared, because what we thought was our second line of defense, like that's gone, right? So now we're looking at agencies and people that we never thought we would call on. And so training them up front to be a part of that for the next time around is going to really save us a lot of heartache and frankly, a lot of money probably in the long run, because we've relied on contractors in a lot of these, in a lot of our jurisdictions. And that's a very expensive and challenging thing to do in and of itself.
This has been a privilege for me to be involved and to spend time with these great subject matter experts and all the subject matter experts who are part of this webinar. We are going to assess, the questions that remain and a lot of the ones we didn't get to. And I think that there's always the possibility we're going to have follow-on and other events that help us continue to move the ball down the field. One of the questions we didn't get to, I wish we did, but it was a theme, I think, of this entire webinar was, what strategies and techniques are employed to share data with partners? What are the pieces of information that are shared from one agency to another regarding sheltering service delivery and those who are receiving assistance? If I were to kind of bang a gong about what that question represents in terms of what we've been talking about today, I'd say it's right near the top. So as a reminder, there is going to be a link today's to recording that'll be available at the CHDS, the Center for Homeland Defense and Security Executive Education Program website. So you can view this again, you can share it with others. We get a lot of repeat views, and that's going to be following this particular session. And as Dawn mentioned, we have 2 more sessions coming up, next Friday and the Friday after. Next Friday, we're going to be focusing on many of the same questions we looked at today, but as it relates to and concerns folks living with homelessness and vulnerable populations. So we're going to talk about emergency shelters from that human service and people living with homelessness standpoint, and dig even a little bit deeper into these very, very good questions that we were wrestling with. The final session actually is an even more kind of complicated topic to discuss, with many public safety implications, as well as disaster population management, and that's jails, custodial settings, settings that people have really no choice but to leave, and what efforts are being taken to de-densify those and other promising strategies. So again, my privilege to be involved with all of you. You are doing God's work out there, and you have my thanks and praise for your everyday efforts and the humanity and dedication and expertise you show in the professions that you have chosen to help others. On behalf of the Naval Postgraduate School, Center for Homeland Defense and Security, and our co-hosts, ASTO, the Association of State Territorial Health Officials, the International Association of Emergency Managers, the National Emergency Management Association, and the CHDS Alumni Association, my sincere thanks for joining us today, and we look forward to continued conversations with you all in the future.